All right. Hello, everyone, and welcome to another session of the Virtual Global Spine Conference. I'm absolutely delighted today to have a very special guest with us today, Dr. Ted Schwartz, who is a professor of neurosurgery at Weill Cornell, also the director of interskull-based surgery and epilepsy surgery. This is a actually a special session for several reasons. And I wanted to make sure I highlight that. Number one, Dr. Schwartz, of course, is a phenomenal surgeon, somebody who I've witnessed doing operations firsthand during my time at Weill Cornell, and I was very lucky to be involved with some of those surgeries in which they needed posterior fixation, which he will talk about a little bit later on. So we have a great guest. We have a great topic, which is a endonasal odontoidectomy. It's really where the skull base meets spine, if you will. And although he's not the first, he's definitely the second skull-based surgeon to be with us on this platform. Although in fairness, the first one, Dr. Chambliss, was with us talking about education and training in neurosurgery programs. So we're honored. Every time we have a non-spine guest, if you will, we get all excited. And the third reason this is a really a nice session, it's because this week literally marks the 3-year anniversary of this program of Virtual Spine, which was born out of Weill Cornell in New York City in March 2020 at the onset of the awful pandemic. So it's just so timely and great to take it back to our colleagues at Weill Cornell and have one of their surgeons there give us the talk today. So without further ado, Dr. Schwartz, thanks so much for being with us today, and welcome to Virtual Spine.
Ali, well, thanks so much for having me. I remember when you started this back at Cornell, it was really what a terrific idea. Its time was right. You made it successful. And it's been going on ever since, which has really been remarkable. So I congratulate you at creating a brand, that's really been a wonderful educational venue for spine. Maybe we need virtual brain, right? Where's virtual skull base? Anyway, Ali, loved having you as a partner and loved getting to know you and your family and just miss you. So thanks for asking me. So yeah, I love the concept of operating on the spine through the nose. When I first had the idea across my, computer and, was involved in the early discussions of it. And that's what was sort of exciting was, I was doing endonasal skull-based surgery early on with a small group of people from around the world. And when this concept emerged, and I'd love to say I thought of it, but I didn't. It just very quickly made a lot of sense and just became another very exciting application for endonasal skull-based surgery. So we jumped on board very early and have had a pretty long experience. So I'm going to talk about that experience and sort of the evolution of this idea in my practice and sort of where we started and the various stages that we went through, because how we do the surgery did evolve a little bit over time. And it's interesting to see how surgical techniques evolve, because usually when you're training, certainly you see it, learn a technique at a moment in time. And, it's nice to see that it wasn't always done that way, even, relatively recently. Let me see if I can advance my slides. I found a way. So just the usual disclosure slides, but nothing having to do with the spine. I'm probably one of the only speakers here with no conflicts in the spine, since I do mostly endonasal and also neuro-oncology. In general, neuro-oncology and epilepsy is my practice. So I'm going to be talking today about ventral cervical medullary junction compression. And the top causes are really either acquired from rheumatoid pannus or congenital. And these are the pathologies we see mostly, which is KRE1 with basilar invagination. And I do have to give a shout out to my partner, Jeff Greenfield, who sees a lot of these patients in his practice and who really makes a lot of the decisions regarding who we will operate on, in that particular area of space. And these patients present with cranial neuropathies, sensory motor deficits, myelopathy, hydrocephalus, and syringomyelia. Those are the most common presentations. And, we don't give everyone an endonasal odontoidectomy, when they come into the office with a Chiari or even a rheumatoid pannus. It really is not necessarily first-line therapy when we think about how we use the odontoidectomy. And for pannus, most people think posterior decompression infusion is adequate, and it probably is in a lot of the cases. And for Chiari 1, we generally start with a decompression with or without a duroplasty, and don't really think about doing a ventral decompression unless the symptoms are progressing, the basilar invagination worsens, in which case then the ventral decompression becomes indicated. And the way I learned how to do this operation, I probably did it once or twice as a resident with Paul McCormick, who you guys all probably know in the spine world, was to do a transoral surgery where, you make a incision, you put the Dingman retractor in the mouth. And those patients, you can't extubate them right away. They have an incision in the back of the throat. You can't feed them right away. They can get velar-pharyngeal insufficiency, and some of them even end up with a trach and a peg. So it wasn't the best operation. This is what that operation looked like, the way I learned how to do it originally. And then, on the left, you just see typical basilar invagination. What you often see is that kinking of the cervicomedullary junction, because there's usually compression in front, and often the tip of the dens will go past the clivus and then pinch it, with the back of the occipital bone there. Now, there are many ways to do an odontoidectomy that are minimally invasive and endoscopic, and the endonasal is not the only way. And I remember John Paul published this article sort of while we were developing the endonasal approach. And obviously, if this is a surgery that's more comfortable in the surgeon's hands because they're more used to going through the cervical spine, this is obviously another viable alternative. I'm not going to talk about it, but I just want to mention it because obviously, I'm not trying to say that all odontoids have to be done through the nose. There obviously are other ways to do this. Whatever you're most comfortable with is probably the right way to do it. So the first case we did was actually transoral. It was a case of tophaceous gout of the odontoid. And we put in a Dingman retractor, but we did use the endoscope. And, the picture on the left shows you this case report that we published actually the same year as Walensky published his case. And this was really transoral before we decided to go transnasal. But you can see in the picture, I don't know if you can see my arrow here, but, where the pathology is, it is kind of below. And I'll talk about this. How do you determine if the pathology is high enough to go through the nose? And the hard palate is sort of a hard stop, if you will. And you can get inferior to the hard palate and the soft palate. And I'll sort of go over the lines that allow you to figure that out. But in this case, the transoral route, which really was the best route, and we were just doing a biopsy there. But then a year later, we did our first endonasal odontoidectomy. And the reason we did it was that the patient was, this was a non-achondroplastic dwarf. He had juvenile rheumatoid arthritis. So there really wasn't a lot of room to go through the mouth. He had a very, very small mouth. He couldn't really open his jaw that much. And we used the ISO-C, which is what we had at the time, to do some intraoperative navigation. And also, began to realize that when you remove the odontoid from the front, you generally destabilize the patient, and they require a fusion from behind almost every time. There have been some papers written about how you try to get away without it, but I think it's really almost impossible in the majority of cases. You're going to destabilize the spine. So we tend to do posterior decompression infusion and then the endonasal odontoidectomy. We have done it all in one sitting. It's a long day and a long operation, but now we usually separate them by 2 days and do the posterior part first and the anterior part second. And the reason I like to do the posterior part first in general is because when you do the anterior part, you're destabilizing the spine, and then you got to flip the patient over. And you never really want to flip a patient if you don't have to in the operating room with an unstable cervicomedullary junction. And then this was the third case. So we were doing them early enough where you could literally just publish case reports that we did. And this was a case of os odontoideum, and you can see that here. And the other thing I want to point out, and I'll show you videos of different ways to do this. When we started doing this operation, and just to point out a little bit of the anatomy, you can see eustachian tubes on either side. And we would make this inverted U-shaped incision and take down what's called the basilar-pharyngeal fascia and show the bottom of the clivus and the odontoid. And it gets you a very wide exposure for sure, but it is kind of hard to close that. You try to flap it back up, but it tends to recede. And so we've changed how we open and close these cases. and now make a vertical incision. I'll show this to you. I just want to point out, of course, VJ, who's my ENT collaborator that I did all these cases with, and obviously Roger Hartle, you're familiar with, is my spine partner, one of my spine partners, who's been at Cornell and the head of our spine center. So when we first started doing these, we kind of wanted to look at the literature and get a sense of what the results were like compared to the transoral. And early on, we published a review of the literature. Rick Homitar, you may know, did this when he was a fellow at MSK across the street. And I asked him to look at, how long it took to extubate patients and how long it took to feed patients. And this was very early on in the endonasal experience. There really were not that many cases out there, but it seemed like the clinical response was good. The improvement compared to transoral was high, maybe higher. But it was also became very clear that the time to extubation, which for transoral odontoidectomy, it's about 3.5 to 4 days average. So you can extubate the patient. Endonasal, it was day 1 or day 2, but usually it was the same day. And in the early days, time to feeding for transoral was 5.24 days, and average time to feeding for endonasal was 3.86. This is now shorter, and I'll show you our own data because we just published our series to date, and I'll go over all that with you guys. We then published a paper looking at the first couple cases we did, looking at how long it took to extubate and feed the patient. You'll notice Roger Hartle, the spine surgeon, Jeff Greenfield, the pediatric neurosurgeon I collaborate with on the Chiari patients, BJ, of course, from ENT, and myself. So these are, multidisciplinary cases, which is what makes them fun, really, because you get to work with your colleagues and decide, how best to do this operation. Tony Goldschlager is a Australian neurosurgeon who did a fellowship with me and then went back to Australia. And he actually has written some great papers on this operation as well as some others. So at that time, we'd only done 9 cases, a bunch of different indications, basiloinvagination, pannus, osteodontoideum. We saw juvenile rheumatoid arthritis. You can see here on pre-op and post-op MRI scan, that you really do get a pretty good decompression ventrally coming through the nose. And we also started to look at this question here, and I was trying to figure out a metric to measure how well we're doing. So I would look at the CSF space between the back of the dens and the front of the brainstem and just measure that. So here you can see it's probably less than 1 millimeter, maybe 1 millimeter, and here you can see it's greater than that. And so we would start to measure that and graph it to get a sense of how successful we were at our decompression. It's not really the best measure because the truth is the brainstem moves forward. So it's actually more of a decompression than that metric measures because the brainstem moves forward, but it does give you a sense of decompression. And so this is that measurement. Preoperatively, in these 9 cases, there was less than 1 millimeter CSF space between the cord and the back of the dens. And then postoperatively, you can see they basically all went up, which is great. And our time to extubation was 0.3 days, and our time to feeding was 1 day. So everybody was being fed the next day, at least liquids. And that's really much better than this old transoral literature. So it shows you that, some objective data that there is improvement in some outcome metrics in doing this surgery. We then looked at the extent of resection for the odontoidectomy in this early series, and we saw that occasionally there were some small fragments of bone, and we tended to leave them on the left side, which had to do with the direction where the scope is usually in the left nostril, and we were coming in on the right. You'd think coming in on the right nostril, we get pushed to the left, but because of where the scope was, we probably couldn't see that well on the left side, and we tended to leave a little bone on the left. So we started to think, well, maybe we should do this with the intraop CT and use the arrow, which all the spine surgeons were using. And you see some more authors here. Harminder Singh did a fellowship with me. Gustavo was a fellow of DJ's. Evan Bander is one of our residents. And here Jeff Greenfield is the lead author on this. Just showing you that how we set up the room when we're using the ISOC, both monitors in the image guidance have to be across from you. It's a little bit tricky, to figure out how you get the patient in there and do endonasal surgery. And this just shows you some of those intraop images. And again, you see this little spike of tumor. Now, is this clinically significant, this little bone fragment on the left side? Probably not. But it definitely was some residual that we didn't want to leave behind. We wanted to try to get a perfect outcome if we could. And we didn't want to have anything, and find out on a post-op CT that we had left something behind that we regretted. And this just shows you that, a odontoid, you can see before and after what that looks like. This is another case. This was one of the, probably one of the deepest. Look at this basilar invagination. Here's the bottom of the clivus. You can see the odontoid pushing way up into the brainstem. I mean, high, it's almost in the pons, right? And so one thing to think about, this is a case where if you're coming in, what I think about is how much of the clivus do I have to drill out just to get access, right? Because we're coming in through the nose, right? So you're going to have to drill off a lot of the clivus. And if you look at the post-op scan below, you can see we had to drill off a lot of that clivus. Even though it looks like there's still some dens in there, all of this tip was removed, significant brainstem compression and to achieve what we wanted to achieve. And you can see that in the circles, that we got that odontoid that was pushing way, way far in. This is.
I know you may cover this, but we'd like to answer the questions as they come in, if you don't mind. So I
Sure, not at
apologize
all.
for the interruption. One question was, when you do these decompressions, are they primarily bony decompressions? And once you get to the ligament, you stop, or are you going all the way to the dura?
Yeah. So we do a bony decompression, and then if it feels like there's some firm ligament that's still pushing in, we'll keep going till we get to dura. Often there is none, because often it's really ventrally pushed in so far that it sort of eroded a lot of the ligament. But you'll see in some of the videos where you see dura there. It just depends what we feel. If it feels very soft, when you're pushing on it, sort of bolotable, I'll stop. And if it feels very firm and hard after I take the odontoid out, I may try to keep going. That's a good question. So this is what the setup looks like. And you can see, the patient can go in and out of the scanner, and we just have to change where the image guidance is a little bit. In terms of surgical technique, this was a paper that Id Hussein wrote. He's another spine surgeon now at Cornell, just showing you the posterior fusion. And it just shows you a couple of examples of how the navigation can help you determine exactly, where you are, how low you want to go, how much of the odontoid you want to remove, what's the relationship between the clivus and the odontoid, which is really important, because when you get in there, things can look confusing. And so you have to expect that sometimes the clivus is literally horizontal, right? You think of the clivus as a vertical piece of bone, but sometimes the clivus is a horizontal bone. And I'll show you a video of this particular operation. So in order to decompress, the decompression here is not just from the dens, it's from the tip of the clivus that's been pushed straight back. So if you don't remove the bone of the tip of the clivus, you're not going to accomplish what you want to do. So you have to drill out the clivus, which is going straight back from you. And I'll show you that in the video. Here's another case showing you that another case we did. You see that posteriorly suboccip, the decompression is very good, but obviously there's ventral compression, very significant syrinx. And after the endonasal decompression, here you can see this is that exact case with the clivus going straight back. You can see we removed quite a bit of that clivus. It looks sharp, but actually because we took off the back of the bone there. And you can see this soft tissue that looks like it's still indenting a little bit, but all of the syrinx has gone away, right? And that just enough of the pressure from the clivus and the dens have been removed, so that even though it does look a bit draped, it's less draped, and the patient's syrinx is gone.
Can I ask you a quick question, Dr. Schwartz? This is Mike
Sure.
again from UNC Neurosurgery. Two questions. What type of drill bit are you using to do the odontoidectomy? Is my first question. The second question is, how are you dealing with the spinal fluid leak when you have such a huge defect? Obviously, this is very different than CSF leak from a pituitary surgery. So I'm just curious.
I'm going to show you that in the last paper, which is our data and our videos. I will show you all of that, but just in brief to answer your questions and not leave you hanging too much. We use a 3mm diamond drill. It's the endonasal drill. It's kind of curved. It irrigates. It's curved a little bit. It's a diamond. It's protected. The whole shaft is protected so that twisting, the bit doesn't grab anything. You'll see it in the videos. CSF leaks, out of like 40 cases, I think we had like 7 intraoperative leaks. So you usually do not get a leak. When you do get a leak, we just put fat in the defect because, it's a deep defect, so you can fill it with fat. And then we close the basopharyngeal fascia primarily with a suture. I'll show you how we do that. And that keeps the fat in place. And then some of them will put a lumbar drain in if it's a really big leak. But again, out of 42 cases, 7 leaks, which is not nothing. It's probably a 18% leak rate, but it's not a huge number. Like in pituitaries, the leak rate's like 50 or 60%. So I'm going to show you.
Apologize again. I'm going to
no problem.
Great question from Mike Selby, who's actually an orthopedic surgeon from Australia. He may know that fellow that you mentioned earlier.
Yeah.
But he's asking about, have you had follow-up on some of the residual bony fragments that maybe you didn't go back to take with the fusion? Have you guys seen that those have remodeled or disappeared or not really?
I have no idea. I haven't followed it. I have no answer for that. I'm sorry. It's an interesting question, and we could potentially look at that. So great question. No answer. So we've done now 42 patients, 11 pediatric. 81% had headaches. 76% had clear brainstem compression symptoms, sleep apnea, cranial neuropathies. 60% had sensory disturbances. 95% had a decompression infusion. About a third were done simultaneously, and 2/3 were done two days beforehand. And obviously, all the QRAs had a posterior decompression. This is the pathology: basilar invagination, 78%, QRE, 76%, just odontoid retroflexion, 69%, some Ehlers-Danlos, cervical instability. You guys can read this. I don't want to go over all the details. And then in terms of symptoms, this is just the list of symptoms: headache, brainstem symptoms, sensory disturbances, dysphagia, velopharyngeal insufficiency, myelopathy. So, I mean, these patients are, significant. They don't just have neck pain. Umberto Tosi wrote this up. One of our residents did a great job, made this figure. I thought it was a really cool figure. So on the left, it shows the time between the posterior fusion and the endonasal procedure. And you can see that the majority of them are 2 days before and then simultaneous. And then there's some who had been fused years before that we then did the odontoid afterwards. And this is the same thing with the suboccipital decompression. And then the figure is on the right just shows you what we fused. I thought this was a really nice figure he made. Which levels were fused in all these 42 patients. And you can see that the vast majority, are occiput to C2 or C3 even, and some a bit lower depending on their pathology. And again, that's not a decision I make, right? And that's the beauty of collaboration. I let the spine surgeon, whether it's Ali or Dr. Fu or Dr. Hartle, you decide what needs to be done from behind. I'm not getting involved. I'm just going to do the odontoid resection. So as I mentioned, we had 7 CSF leaks. They were closed either with a fat graft only or a fat graft plus a lumbar drain in 5. And we had no post-op CSF leaks. And, if I have a leak and I want to close it up, a lumbar drain will definitely throw it in because I'm much happier putting a lumbar drain in than having a patient get meningitis in a CSF leak. So, sometimes they'll get some spinal headaches, and you take it out. And I'll usually leave it in 2 to 3 days, not too long. All right, so this is how we did our measurements. And these are the lines. And I kind of want to go over these because they're sort of interesting. But the yellow line is the hard palate line, right? So that's just a straight line back from the hard palate. The other line, the blue, the nasopalatine, you take the bottom of the nasal bone and you bang it across the back of the hard palate and you see how low it takes you, right? And then there's these 2 other lines I want to mention, the nasoaxial line and the rhinopalatine line. Basically, they start somewhere in between the 2. So the red one, the nasoaxial, is halfway between the bottom of the rhinian and the hard palate line. And then the rhinopalatine line goes a little bit lower, it's 2/3. And the reason we have these lines is which line, here's the question, which line is going to predict how low we can get when we do our odontoidectomy. So what we do is, the way we make this study is we do our odontoidectomy, and then we go back and we say, all right, which of the lines that we draw predicts what we ended up doing? And then we see which one is the most accurate. The other thing we could do is to measure how much of the odontoid do we get out? Like how successful are we? So you have your odontoid length, your pre-dental length minus post-dental length is your dental resection. You can say how many millimeters we resected of the odontoids, what percent we resected, and what percent of the total height of C2 did we remove. So we measured all that. Umberto did all these measurements to try to really give us some information about what we're accomplishing. And then the question of the CSF space measurement, we did the same thing that we did in that original paper with Tony Goldschlager, but we did it now in 42 patients instead of 9 patients to see how much the space increases and how does it increase over time. The CSF space in front of the brainstem. Now, I'm going to take a backtrack and talk about the lines because the first time we published about the lines, we decided that the rhinopalatine line was the best predictor. And just to go back, the rhinopalatine line is the one that's 2/3 down from the bottom of the nasal bone. That told you how low you could go. And that was a study that Emmanuel Laporte did. He was an Italian guy who did a fellowship with me, and he did it very early on. He was looking at 8 cases, so it's very small. And these are some of the cases that we did. You can see this MRI of this, ventral cyst here and how it's gone here. And he drew all the different lines and tried to figure out how low we go. And here you can see the yellow line tells you exactly how low you can go. And it starts 2/3 of the way down between the palate and the palate line and the nasion. And the same thing here, he didn't draw it here, but this would show you where that yellow line would predict we would be able to go. How low can you go? And then here it just shows you that Rhinian line saying, all right, so if I look at this case, I should be able to remove the odontoid down to about here. And this shows you the rhinopalatine line predicted that we could go 12 millimeters down, and the inferior surgical extent was 10 millimeters down. And so he said this line is the closest, it's better than the nasoaxial line. So that was our original data. This is the data from the 42 patients. And what we found was more or less the same thing, except to say that it was in between the two. The rhinopalatine line wasn't perfect. I'll show you the actual data. The nasoaxial line, it was right in between the nasoaxial and the rhinopalatine. That's what the conclusion of this one was. And if you look at the amount of dens that we can remove, it's about 12 millimeters. The dens resection, we can get about 12 millimeters of dens, which is a lot. It's over a centimeter of the tip on average we removed. This shows you how well the nasoaxial line and rhinopalatine line measured. The dotted line is what we did. Again, it's that about 12 millimeters of dens, and the nasoaxial line predicted, 14, and then rhinopalatine predicted 8, but it's somewhere in between those two. And then the other question we were addressing is that CSF. How much CSF do you get in front of the brainstem? So beforehand, you would measure it. It was about 1 millimeter. Afterwards, about a month or two afterwards, it was about 2 or 3, and then it would go up to 3 millimeters. And this was statistically significant, that actually the CSF space in front of the brainstem increases over time. But the surgery is very successful at decompressing the ventral brainstem. Not surprisingly, we're able to get out enough bone that we can do it, and we can predict it with somewhere between the nasoaxial line and the rhinopalatine line. Median length of stay was 5 days. Median time to extubation was 0. Median time to oral feeding was 1 day. One patient had a trach and a gastrostomy tube for medical complications. 4 patients had transient dysphagia on discharge, but were able to tolerate oral feeding and eventually returned to regular diet at their first follow-up examination. All but 1 patient had improvement in their pre-op symptoms, including a patient who required the trach and the G-tube. 1 patient had no benefit from surgery, but had adjacent segment disease to his posterior fusion. And when I show you the complications, the biggest complication was suboccipital wound breakdown. So I was happy to see that it was really the spine surgeons that were having all the complications. It was not me.
Ted,
in terms of meningitis, we had 1 case.
I noticed that in the paper. I noticed you put that in the paper, that all the complications were from the spine surgeons. But in our world, we count CSF leak as a complication. So
no, there's 1 CSF leak. It's not
over 10% of patients had CSF leaks from the front.
No, that's during the surgery, not a post-op CSF leak. That's not a complication. I'm just to clarify. If you get a CSF leak during the surgery, as long as you fix it and they don't have a post-op CSF leak, in my opinion, that's not a complication.
Ted, joking on the side, that is a question that comes up a lot in the spine world. Yeah. And it's funny because we talk about this a lot online with other colleagues, whether if you're doing a spine operation, a lumbar lamina fusion, you get a CSF leak, and let's say you repair it, you suture it, there's no sequela. The vast majority of us actually dictate that as a complication. It's a surgical complication. But I'm glad that in the skull-based literature, it's not a complication.
Right. I mean, if you think about it, if you were a skull-based surgeon, first of all, when we take out pituitary tumors, 60% of them get a CSF leak. 56. I mean, for a tiny tumor, no, but if you average all your tumors together, it's like 50%. So it's a part of the surgery. You just have to fix it. And obviously, if you're doing skull-based surgery and you're intradural, 100% of them have intraoperative CSF leaks because you're opening the dura. So you're right. It's just a different perspective. So that's very interesting. I'm glad you mentioned it. Here are just some examples of cases, pre-op and post-op. So I'm going to show you the video. So this is the early video. I'm showing you a video of this is not how I do it anymore, but I just wanted to show you the U-shaped flap and taking down the vasopharyngeal fascia off the clivus and then taking it down. This is the soft tissue. Often a lot of the soft tissue is actually in front of the dens until you get to the bone. And I'll kerrison that out. Sometimes I'll even cavitron that out. And then we'll drill it out. This is the old drill. We use a different drill now. Here's the cavitron, showing you the cavitron and some of the soft tissue when it's really bad, and then trying to drill more of it. Because it's very hard to get instruments in there to remove ligament and tendon. It's so firm. And so I really go down as low as I possibly can. I remove as much bone as I can. And then often we'll curette out the last little bits of bone that are stuck to the ligament. And then you see there's a fairly deep hole in there, right? And so I'll show you how I close now, because how I closed before is not that important. But I would try to put the flap back up. I sometimes put fat if there's CSF, if not, flap up and just some fibrin glue. We had one patient, I will mention, where we put Duraseal and it fell down and the patient aspirated the Duraseal. So we try not to use any sealants because there's nothing to hold that sealant in place. They're just, when the patient gets extubated, they can just aspirate it. This is another case that had, you see this bowing of the ligament in back. You can see here the bowing of the ligament behind the bone. The bone is not that much retroflex. It's really the soft tissue. So you asked me the question, would I just take the bone? In this case, no, because I know that there's a lot of soft tissue. Sometimes the bone is what's pushing back, but here you can see it's the soft tissue. You also see this interesting ossification in front. And obviously, I pay attention to this because when I go in, I want to make sure I find this and drill all this out. Otherwise, I'm not going to get where I need to go. So here's that case. We're working between the eustachian tubes. Now we make a vertical incision, and I'm just using a Bovie extender. And you can see the vertical, because the vertical incision does get you lateral as far as you need, and it's much easier to close. So we start drilling. You can see here now it's a more modern drill. It's protected all the way down. The new ones irrigate. This one might not be irrigating, but then kerrison, you get the soft tissue. You try to find the bottom of the clivus. And there you see the dura in the back. The dura is coming into view. You see it's pretty soft because I've taken off a lot of that soft tissue with the kerrison. And then here, there's no CSF leak, so flow seal. How do we close? Chromic suture, put it through the same nostril, and then tie it outside. And I just push it down with an endonasal ring curette that I use. So you have to tie the knot outside and push it down. And this just shows you post-op that the odontoid has been removed. And you see, not most of the soft tissue is gone, but the compression is gone as well under that ventral brainstem. And you see that little knuckle of ligament has been removed. Ibn Hussein put this together for me. I'm going to present it. 14-year-old, Chiari-1, 2 prior surgeries, suboccip, laminectomy, duroplasty, still had headaches, myelopathy, snoring, cranial nerve, sensory motor. Here's the ventral compression. You'll see it in the clivus is going straight back. This is that case that I showed you. There's that clivus going straight back. You can see, you have to take the anterior ring of Sing 1. It's in your way before you get to the odontoid. So that's the anatomy. He had a repeat suboccip and an occiput to C4 arthrodesis. That was done on day 1. 2 days later, we came in. Young kid has more soft tissue back there. You see the ventral incision. You see the curved drill showing you the navigation, how low we can go, and drilling it out till we get. And here, bone is there's not a lot of ligament behind the bone. And you'll see that here. So here we drill out the odontoid till there's just a shelf of bone. You can actually see the ligaments lateral and superior. And use the kerrison. There's not a lot of room. You can see I'm bumping into the endoscope a little bit. And then there's a little shelf of bone that I need to get out. And then once I get that out, I have to take the clivus, right? So now I'm going to take the soft tissue down from this clivus that's going straight back. We talked about that before. And I'm going to start drilling the clivus. And I'm going to drill the clivus all the way back until I get to soft tissue and, hopefully don't get a CSF leak. And get that out. Kerrison. And then here's that suture. It's a tricky suture to put in, I'll be honest with you. It takes some playing to do it well. And we'll put more than one, sometimes 2, sometimes 3. Here, this is a proline And then I like to use chromic. I'm not sure why we put chromic in there. Maybe I didn't put that suture in. But that's the post-op. So patient did quite well. Here's another example, just a dramatic ventral compression, just trying to show we're not just decompressing, unnecessary surgeries here. These patients have pretty significant compression. So in conclusion, endonasal endoscopic odontoidectomy is an effective and safe treatment for ventral cervical medullary junction compression with posterior surgery alone is not adequate. It is in general combined with the posterior decompression infusion done beforehand because you will destabilize the patient and you have to be aware of that and take care of that problem. So that's it. That's my talk. Thank you very much.
Great. Thank you. Thank you so much, Ted. Obviously you're a pioneer and obviously my regards to Jeff. Dr. Greenfield also has been very active in this area, but technically speaking, I can say firsthand that I actually saw this, and although I don't do any skull base or endoscopic surgery, I will let the audience know that I used to come into the room to see that part because it was just, technically very, very, very gratifying and very nice to see. We got a couple of questions, Ted. Obviously, when you're doing the endonasal odontoidectomy, how do you navigate the vasculature? How do you ensure that you're away from the internal carotid the internal carotids?
So believe it or not, I almost never pay attention to the vascularity because you really can't get there. You are limited in how lateral you can go. And you're really just, once the odontoid is gone, you're basically done. So, I mean, sure, will I glance at the MRI and make sure that the vert is not in some crazy atypical or that they're not rotated. And I mean, if they're really rotated, you could imagine something crazy happening. So barring anything like that, where I almost never even think about the vessels because they're literally not in the operative field in almost any of the cases that we do.
Got it. Thank you. We have with us also part of the faculty of this program. Again, Dr. Galgano, who you met, Dr. Mamagani, who's an orthopedic surgeon from Switzerland. Alex, do you have any questions for Dr. Schwartz?
Yeah, Dr. Schwartz, Mamigani from Switzerland, Alexandria. Impressive talk, impressive surgery. I don't know whether there's any skull-base surgeon in Switzerland at all who has who's able to perform these. My questions are just technical questions. What diameter is the endoscope, and do you fix this endoscope rigid on the table? Because the pictures, the video you're showing us was very calm, no movement. And can you use different angulated optic like 25 degrees to gain a little bit more in up and down or to the side?
Yeah. So first question, it's a standard 4 millimeter scope that we use for skull base surgery. It's part of the Casabianca set. It's got a sheath around it for irrigation. They do sell a pedal you can use, but I just have the assistant basically take a syringe with a tube with IV tubing and just irrigate and then suck back the drops. So someone is always irrigating the sheath. I put my endoscope on a scope holder. I don't have somebody hold my endoscope, and I do that for all my cases. And I'm very different than the Pittsburgh group, which is sort of another school of thought on endoscopic skull base surgery. And they have raised a whole group of surgeons who where someone holds the endoscope. I don't like it when the endoscope is held because for the most part, it's like having someone hold your eyeball and having your eyeball move around. I like my eyeballs fixed in space. I will frequently move the endoscope. The endoscope has to be moved, but once I get it in the position I want it not to move. And I'm just very good at moving it and then locking the bolt, keeping it there, operating, and then going back. With regards to angled endoscopes, most endoscopic surgeons will tell you that they prefer to operate with a 0-degree scope. That the image is better, the surgery is easier. They'd rather remove some of the overlying tissue or bone in order to get a 0-degree scope in there. But that being said, we use angled endoscopes all the time and we operate with them. But the instruments are not as good that are angled to get there. So for the odontoid, though, because it's such a deep cavity and it doesn't really open up as you get deeper, it only gets narrower as you get deeper. An angled endoscope, I don't think would give you that much of an advantage. I think you see everything with a 0-degree scope because you're working right down a tube. When we use an angled endoscope, it's when we want to go in a cavity and look off to the side, right? But we don't really have that in the endonasal odontoid approach. So it's mostly 0-degree scope on a scope holder, 4mm scope with a sheath.
Oh, thank you.
All right, wonderful. Thanks so much, Ted. I appreciate it. We have about 15 minutes or so left. I was going to take over the slides and just talk a little bit about the posterior part, which is the OC fusion, as Dr. Schwartz mentioned that many times, almost always, we would fuse posteriorly first to ensure that there is no instability with the dens resection. So I'm going to go ahead and just share some slides here. And these are important pearls, not just necessarily for cases in which someone is getting a dens resection, but also for OC fusions in general. Here are a few slides on OC fusions and complication avoidance for the spine surgeon. Obviously, we know these are high-risk surgeries, and as Dr. Schwartz mentioned, they are fraught with complications. Wound healing, certainly, especially in EDS, connective tissue disease, sometimes elderly patients, that area can be very difficult to heal. We, as always, we have many trainees with us, and just to give Dr. Schwartz some background, we usually have 30 to 40 live participants and several hundred viewers later on YouTube. So we're going to have many surgeons and trainees watch this later. But from a technical perspective, of course, you have to study the anatomy, you have to review the images. But just like Dr. Schwartz mentioned in the anterior part, in the posterior part, you really have to know what the danger zones are, and you have to have a backup plan. Fixation tends to be challenging in some of these cases, especially if you have basilar invagination, osteogenesis imperfecta, multiple Chiari decompressions. The anatomy is just not the same. It's different. It's been changed. It's been morphed. So you have to know what the danger zones are, and you have to have a backup plan. Sometimes you can put in screws. Sometimes you have to put in wires. Sometimes you have to put in plates. So you have to have a skill set that's a little bit versatile and flexible in order to achieve your fixation. Everybody knows this is basic anatomy in terms of where you want to place the occipital plate. I always have bone wax ready because sometimes you can get into pretty significant bleeding from a venous lake in the bone. But in general, even if somebody has had a Chiari decompression, we have found that you can still manage a plate in the keel slightly above the decompression, which is more robust than the lateral aspects of the occipital bone. Usually a midline keel is preferable. 8 to 14 millimeter screws is the average. Everybody knows that you want to tap all the way because this is cortical bone. Otherwise, the screws are going to strip. And I tell everyone this is one of the very, very few parts of the body. I used to say the spine, but the occiput, let's just call it C0 for what it's worth. It's the only place where if you drill and get bleeding back or CSF, you can still put the screw in. So never hesitate to plug that hole with the screw if you get CSF or of course, venous bleeding. That's, of course, not the case in other parts of the spine. This is one example. This was a very young boy, maybe 5 or 6 year old boy who had a previous multiple Chiari decompressions, was having persistent symptoms. And, you can really put in instrumentation even in young folks if needed. And again, here we had to use wires because we just did not even have enough for a midline plate. Everybody knows that the number one vessel to watch out for in OC fusion is really the vertebral artery. I've posted this picture before. My favorite view is the parasagittal CT, and you really want to see how high riding that vert is. And you always want to see that before surgery, not during surgery. Because if you just put a very long par screw, it's very easy to get into that canal. There's plenty of published literature on this, of course, the difference between a par screw and a pedicle screw. These cases, as we've discussed before, are very easily accomplished with freehand technique, minimal fluoro. I'm not a big fan of nav for these, although now as I get more comfortable with navigation, I'm trialing navigation for different entry points. But for a long time, I've really done this freehand. And I believe it's probably more reliable when you have direct visualization of the anatomy. And somebody asked a question about the carotid arteries. We know where the carotids are in the front. We know where the vertebral arteries are, and that's important for C1 and C2. I always say C2 is king, right? Because C2 is so robust. You can put pars screw, you can put pedicle screw, you can put laminar screw, translaminar screw, or as in this case, I put in all 3 screws in one C2 vertebra to achieve the most robust fixation. But when we're talking about OC fusion, again, you have to be a little bit versatile. Sometimes you can use plates, wires here in the middle. I don't do that as often now. I don't necessarily use rib graft or strong structural allograft, which I know the purists among us still believe in the allograft. I have full faith in the biologics that I use now, and I'm very happy with the fixation that I rarely harvest a rib graft or put a structural allograft there. But sometimes you do. Sometimes you do have to do that. We talked about this before. Navigation, just be very careful when you use nav at C1, C2 because of the hypermobility of the high cervical spine. But this is really what I want to show. This is what I want to highlight, which is very important to also what Dr. Schwartz was talking about, which is the optimal position of these patients. We all know this when it comes to OC fusion, right? You don't want to tuck their chin in, and you don't want to lock them this way. Otherwise, they're not going to be able to breathe. They're not going to be able to swallow, and they're going to be very unhappy. So this patient who underwent an OC fusion, obviously suboptimal positioning. And what I look at a couple of things, I like to see the eyes vertical to the ground, but I also like to see a little bit of space in that retromandibular space, or what I call the angle of the mandible. If the angle of the mandible is touching the vertebral bodies, they're probably too flexed. So you want to leave a little bit of space between the angle of the mandible and the spine on a lateral fluoroscopy. So we don't want to fuse patients in birdwatcher's gaze, which is looking up, or reader's gaze, or now we call it text gaze, looking down. Those are and obviously if you have to choose one, looking up is always better than looking down, but neither of them, of course, is optimal. So the alignment in OC fusion is just as important, and if not more important, than the actual fixation. So this is that patient I was talking about. She had to be brought back to the OR. You can see that she's tucked in, she's flexed. You can see the neck folds. That's not what you want to see. That's not optimal alignment. You really want to extend that a little bit. So that's how that patient looks now, extended with no neck folds, eyes looking straight down, and an X-ray demonstrating good space or ample space behind the mandible. And I just want to show this here. This is a video that we put together where if you use the Mayfield clamp, which we do, you can easily adjust the alignment with the knob. So you open the knob, you extend a little bit, and you flex depending on what part of the case you're doing. And Ted, I can tell you that Jeff really enjoys this part of the case. I mean, this used to be a really fun part of the case because we can really dial in the amount of flexion or extension simply with the Mayfield knob. So you really have to be careful on how you fuse these patients. So that's it. I just wanted to show a few slides on some pearls and tricks with OC fusions. But obviously the highlight here was Dr. Schwartz. Ted, we've got a couple of minutes. Can I run a couple more questions by you?
Yeah, sure. Of course.
Okay, great. Somebody said, what do you do in those few cases of CSF leak, even after the fat, even after you put the piece of fat graft? Do you go back and put a lumbar drain first, or do you put a lumbar drain and explore? How do you manage that?
Well, as I said in the series, we haven't had any patients where our closure failed. But because you can close the pharynx primarily, and sort of lock that fat in. And because it's a deep hole, so it lends itself to fat staying in that cavity. The closures are pretty sound. So we do fat, primary closure, lumbar drain, and we haven't had any problems yet. If so, the question is, if I have a subsequent leak, someone developed meningitis, I would obviously start them on antibiotics. I'd put a lumbar drain in, get a CAT scan to see if it's pulling in air or not. But in that situation, I'd probably go back and try to pack more fat in there, maybe put some, I use some of the tricks we use endonasally. So I think to myself, all right, maybe I can get some Alamax as an inlay to cover that and then put the fat on top of it. Put sort of a barrier onlay, or even some Duraform inlay, and maybe even a button closure with two layers with a suture in the middle. Like, as an endonasal skull-based surgeon, I know as many tricks as there are for closing CSF leaks. So we have a lot of different techniques that we can use, and I would see, based on the defect, you kind of figure out which one you think is going to give you the best result.
Perfect. Wonderful. Okay, great. Any last comments or questions from any of the faculty?
Yeah, I have a last question. Dr. Schwartz, are you able to have a look into the joints, to the lateral atlantoaxial joints during the surgery, or are you not able to go to the site so far that you can see the lateral joints?
Yeah, so there's two questions. One is, are you able to? And the other one is, do I? So the answer of do I is no, right? I'm just trying to get the odontoid out and go home. And can you? The answer is you might be able to if you were more aggressive laterally and took down more tissue. You might be able to see the joint. I actually worked with a resident. I've worked with a couple with the idea of, hey, can we do, you'll appreciate this, can we do a fusion from the front? Can we do an endonasal fusion of the clivus to C2? How wouldn't that be great? Or C1? And the answer is you can actually technically sort of do it. I think it would be somewhat tricky, but I know fellows of mine who have written papers on it, who have tried to patent different ways of doing a ventral fusion, and it would be kind of cool to be able to do it well. I think if the equipment were developed to do it, you could definitely, get a screw into the clivus, right? That's not that hard. And you could probably get two sort of lateral screws going to either side into C1, 2 through the joint. If you go into the brain lab and you kind of map it out, you say like, hey, I could probably do this. It would be pretty cool. So
no, it's probably really hard. Don't work on it. I don't recommend doing that.
Yeah, and I'll start clipping aneurysms through the nose.
I mean, so I'll just close up by saying one of the things I remember telling Dr. Schwartz when I saw him do these cases, and I remember this vividly, I used to always tell him, you basically took one of my favorite operations, which is the transoral odontoidectomy. I was proud that, I was one of the few people at that time and there that kind of was comfortable doing it and liked to do it. But there's no question that when you see the outcomes, you see the recovery, there's no question that this is better for patients. So it's okay when somebody does it better and does it for improved patient outcomes. So
yeah, I mean, that's always the challenge of these minimally invasive approaches, is proving that they're actually better for the patient. And so I've definitely spent a lot of my career really trying to look at my outcomes and trying to compare it to the open outcomes and see, in which cases it's better. And ultimately, the conclusion I've come down to is it's all about case selection, right? So a lot of people, when we're talking about meningiomas and craniopharyngiomas and chordomas, and which do you do minimally invasive and which do you go through the eyelid and the eyebrow, blah, blah, blah. If you choose the right case for the approach, you'll get a great outcome. If you choose the wrong case, you're going to get a bad outcome. And it can give the approach a bad name. But some of the people who have complications and problems, it's because they're choosing the wrong case. It's too big a tumor. They shouldn't have been doing it through a minimally invasive approach. They don't have the adequate equipment. They don't know how to close well enough, and you get bad outcomes. So it's really about choosing the right case and then having the ability to perform it.
Right. Wonderful. Dr. Schwartz, thank you so much for joining us. Please give my regards to the colleagues back there, and I'd love to have you again in the future.
Great. Thanks so much, Ali.
Okay, guys. Have a great evening, everyone, and
care,
we'll see everyone next week.